So, we're going to talk about the second trimester of pregnancy and start a little bit of the third. Here are your objectives. Just remember, this is focused on a low risk singleton pregnancy. We will get into more complications of pregnancy next semester. So, second trimester is the end of the 13th. So, 14th week through 27. So, 14 and 0 through 27 and 6. Most women are most comfortable during this period of pregnancy. Those first trimester issues have gone away. They're not urinating all the time. They're not as tired. Those hormones are nice and comfortable for them. The uterus is growing quickly, but it's still pretty low in the pelvis. So again, sometimes they will get fatigued. A term or a phrase that I often use is that you are growing another human. So you're going to be tired, you're going to be hot. All of those things are very, very normal. They typically will have an increased appetite during this time. It's, a couple things. That baby's growing really quickly and needs extra nutrition. And if they've had any nausea and vomiting, then everything starts to sound good. So, texts are going to give you varied quickening times. So quickening is when moms first feel those flutters of the baby's movements. The earliest I really have ever seen is 17 weeks. Some textbooks will tell you as early as 13. I've never ever seen that. So typically around 20 weeks for first time moms, if they know what that is. So that can be certainly earlier in moms who've had pregnancies before because they recognize what they're feeling. Some pregnancies where the placenta is on the anterior uterus. So we'll talk about placental placement as well. But so the baby is inside the uterus, and then you've got the uterine muscle. Then you have baby, placenta, uterus, adipose, fat tissue, and then skin. So really what they're feeling is the perception of the change in the skin. That's what you can feel. Even though you may not see it, that's the feeling. That's where those nerve endings are. So if you've got another, half an inch or inch thick placenta, depending on where it is, it can take longer to feel baby's movements. Typically you're not going to know where that placenta is until around this time because you do that anatomy scan usually between 18 and 21 weeks. But sometimes earlier in pregnancy you can tell where the placenta is going to be. So moms generally have their nice little belly bump and they look cute and they're excited and they feel good. So these are your goals of prenatal care, right? So early and continuing risk assessment, which is a normal, nice, normal, boring pregnancy. Sometimes moms will be like, why do I have to come here? Especially if they've had babies before, because it's a continuing risk assessment. You never know, pregnancy, just like in the ER or labor and delivery or anywhere, everything is fine until suddenly it's not. So we're trying to watch and catch those early signs of things before they actually happen. Health promotion, obviously, which means education and telling mom what to prepare for and what she can expect to happen next. And what she needs to keep up with and what she needs to do. And then, of course, any medical and psychological interventions. So say she does develop, a vaginal infection, we're going to treat that medically. If she does start to develop mood discomforts or mood issues, we're going to address that however we need to. So those are your three components that you want to remember. So routine visits every 4 weeks until 28 weeks, and then typically every 2. I know some places do every 2 to 3. 2 is kind of the standard, but if your only options on your certification exam are 4, 3, or 1, it's generally you would pick 3. But 2 to 3 is really your answer. So every time they're in the office, you're going to do a weight, a blood pressure, a urinalysis, and these are the things that you're looking for in urinalysis. Some offices use the 4 indicator dipstick. Some use the whole long one with 9 or 10. I don't know how many are in there with specific gravity and all of that. But these are the main things that you're looking for. And then, of course, we're saying, hey, mom, how are you feeling? Do you have any concerns? Do you have any problems? So that's telling you what she has going on. You obviously are going to have a lot of things to say to her. You discovered that in your new OB video. There are a lot of things to talk about, especially in a first-time mom. So, just like any other physical exam, you are looking at her, you are talking to her, especially if it's someone that you've seen throughout the pregnancy. You may catch those mood changes. You may be able to recognize them. Some people are really, really good at hiding how they feel. But typically, if you develop that open, trusting relationship with them, once that door closes, and it's only the two of you in the room, that is part of your responsibility. Obviously, that depression scale, we're going to pound that into your head. It should be done at the first newbie visit, which a lot of you guys did not discuss in your video. And then once a trimester. Not everyone does that. I do know that, but it should be done. And then, of course, if you have concerns, if she tells you that she doesn't feel well, or you get a feeling, your nursing spidey senses start to go off, then you're going to do that scale. Okay. There is an anxiety specific scale, which sometimes is a little more common in pregnancy and postpartum, called the GAD-7, GAD-7. So, if you think something is going on, or she tells you she's anxious, and you do the EPDS depression scale and it's normal, then I would definitely go ahead with the other anxiety screening scale. The great things about, one of the many, but the great thing about these scales is it tells you the answer, right? So you don't have to think, okay, she scored a 7. What does that mean? There is a second page where you add everything up, or if you're using an app or an iPad or something like that, it will total it for you and actually gives you the diagnosis. So you're still using clinical decision making based on what she tells you and what you see, but you have a measurement that says possible mild depression, consider this, this, this. So it gives you a guideline for where to start. Starting at about 15 weeks is when you're actually going to measure the fundal height. So at about 15 weeks, the fundal height is halfway between the pubic symphysis and the umbilicus. So I obviously do feel before then. Before 12 weeks, you may be able to feel kind of some fullness when you press slow on the pelvis, but generally I'm just making sure that the uterus is growing. So at 15 weeks, you're usually seeing them back about 14 or 15 weeks, depending on when they started and how their appointments fall. But at 20 weeks, it is right at the umbilicus. Now, there's certainly going to be variations in this, right? Let's say a mom who's, multigravida, she has that diastasis rectus where her tummy muscles have pulled apart. It may feel different. A mom who has uterine fibroids, where that uterus already was enlarged and abnormal shaped, it's obviously going to continue to feel that way. Oops. Sorry. So again, back to that sequential screening for birth defects. If you're doing that sequential or integrated screening, this is the time for that second part of the testing. So we do, a maternal blood draw. That's our AFP. It does include those initial hormone screening portions that you did in the first trimester. You're also going to hear my dog bark because he's really old. And when he goes to another room, he gets lost. If she is just now presenting to you for care, so she presented, outside the first trimester and she does want screening, this is where that quad test or quad screen comes in. About 20 weeks, but depending on where you are, 18 to 21 is still pretty normal. Again, depending on if she presented late to you for care, is your anatomy ultrasound. I would encourage you guys that anywhere that you have an ultrasound, a sono technician in your office, that you ask to watch a couple of anatomy scans. If not, we have some options for specialty rotations in your third trimester, and you will definitely get to see those then. Pretty much the only ultrasounds that you would do as a nurse practitioner would be, sometimes I will do a handheld ultrasound to, let's say I can't find that fetal heart rate or rhythm with the Doppler, and it's she's, let's say, before 15 weeks and I can't find that baby, I'll go get an ultrasound and just take a look to know better where to listen. You can diagnose a pregnancy loss, so you could look and see if there's bleeding. I have an ultrasound certification, which you can get one as an RN actually through the Board of Nursing, but that's basically just giving you very, very limited ability to use ultrasound as a prudent nurse in the same situation would. So I'm not going to put an ultrasound on a belly and do an anatomy assessment. I am not qualified or trained or certified to do that. And even as an ultrasound tech, they require additional certification for OBGYN. So they're going to do a detailed anatomy assessment. So every organ system. I think we've already said that before 20 weeks, usually about 18 to 20 weeks, every single organ system has been created and developed. So that is why we do that ultrasound at 20 weeks. If you have a mom with a large BMI and she has a lot of adipose tissue in her belly, sometimes they cannot complete the anatomy assessment because of how baby is laying or where the placenta is, and that ultrasound wave has to go through all of that tissue. So sometimes you'll have to reschedule those ladies. They'll do as much as they can, and then the tech will give you a note that says she's going to have to come back in 2 to 4 weeks, and then you go over what you have available, and then you follow up and you typically call it to complete anatomy. We do look where the placenta is, make sure that it is attached in the appropriate place, that it is completely attached, where the umbilical cord is attached to the baby, and where that cord is attached to the placenta. Placenta obviously is the queen of the world in a pregnancy. So knowing what's going on in the placenta is key to oxygen and nutrient transfer. The hormones that are produced by the placenta can cause or prevent so many problems. And then at about that time during the anatomy scan, they do measure a cervical length just routinely. So you're going to, again, find various numbers. This reference gives us less than 25 millimeters by transvaginal, shows an increased risk for preterm birth. I've seen cutoffs as 3 millimeters. Obviously, the more conservative measure, or whatever your supervising physician agrees on or your facility agrees on, is the guideline that you will follow. So some things we do around this time of pregnancy. The glucose tolerance test, or the screening for gestational diabetes, is between 24 and 28 weeks. Again, you're going to find variation in when providers prefer to do this. The kind of standard Most places is at 28 weeks, but if they're anywhere in that range, you can do the glucose tolerance test. So it's 1 hour, which means they drink 50 grams of glucose, um, which is super, super sweet. It doesn't taste great. It tastes like a really flat soda of whatever flavor it is. Typically, your office is either always going to have the same flavor. They may have three options, or it's just whatever the lab sent them. They used to have coloring in them, but now you can get them without artificial coloring, and it's just clear with the flavor. These can be done fasting or non-fasting. If they're fasting or not, if they're fasting or not, that's going to change your interpretation of the lab result. Um, so, in a woman with significant risk factors, so significant obesity, maybe prior gestational diabetes, or strong family history of diabetes and obesity, you can screen them earlier in the pregnancy. The official way to do that is with the 1 hour glucose test. Some people do a hemoglobin A1C. It's not the best option. Some practices do a hemoglobin A1C with every single new OB. So you'll just have to see. I'm telling you what's supposed to be done, and then you will learn and figure out what happens in your facility. So although you are testing it, it may just be done in a different way. In a mom with diabetes, I cannot stress this strongly enough. If she has diabetes type 1 or type 2, you do not screen her for gestational diabetes. You're not going to give a diabetic 50 grams of glucose. I have seen that happen before. It's not pretty. So they do not need to be screened. We'll go over the results in a minute. Okay, so when you see them at their first new OB visit, one of the tests that you do is their blood type and RH factor. If you don't understand RH factor, please let me know, because it is very important, and I will also explain it to you guys how I explain it to patients, because as you know, I feel like if you can explain it to a patient, you actually understand that. Okay. So we know what blood types are, and the RH, the way I explain it is, okay, all of your red blood cells are donuts. So when we do the blood type, we figure out what kind of donut it is, right? Is it a chocolate? Is it a, I don't know what those are. Just a regular donut? Is it chocolate? Is it a cake donut? We're figuring out what kind of donut it is with the blood type. The RH is, are the donuts with sprinkles or without sprinkles? So an A positive is a donut with sprinkles, right? So now we don't know Dad's blood type. A long time ago, they used to draw Dad's blood to see what his blood type was. We don't do that anymore. Can we assume that the husband or the person that she says is the father of the baby is, hopefully, but maybe she doesn't know, or maybe other things, right? So we just proceed with this standard of care. So if the dad has a donut with sprinkles, no problem, right? Mom and dad both have donuts with sprinkles, perfect match, everything is fine. If mom does not have donuts, if she does not have sprinkles, so she's A negative, and dad has an RH of positive, when the body sees that RH factor present, it knows that it's not normal, right? So it's foreign to the body. Now, the baby's blood is created by both parents. So the baby could have mom's blood type, or the baby could have dad's blood type. So if mom is RH negative, dad is RH positive, and baby in utero is RH positive, In a first pregnancy, it's fine. Maternal and fetal blood, the actual blood, do not interact with each other during a pregnancy, which is pretty amazing if you think of it. But if there's any bleeding during a pregnancy, there could be transmission of baby's blood into maternal bloodstream. If that happens, then the maternal blood system, the immune system goes, oh no, this is bad. This is a foreign body. It's not supposed to be there, and goes to attack the sprinkles. And the baby has sprinkles, right? So in a first pregnancy, not an issue, because the maternal blood doesn't have any way to get into the fetus. What can happen is, or what used to happen, and still can, when a mom is Rh negative, baby is Rh positive, she delivers that baby, there is mixing of blood, let's say at delivery, and then the next time she gets pregnant, the body automatically recognizes that as foreign and causes an isoimmunization where it attacks the baby's red blood cells. Again, that's a complication of pregnancy that we will get to in the next semester, but that's the point of, that's why I want you to understand that RhoGAM is so important. So typically when you do their diabetes screen, you're going to draw their antibody screen again, which if nothing has happened, it should still be negative. And then you're going to give her RhoGAM. So at that diabetes test, you're going to do generally the 50-gram glucose. Then you're going to do her CBC or H&H there. And I hope you remember why. And then if she is Rh negative, you're going to do an antibody screen to make sure that new antibodies haven't been created. So again, rescreening has not been shown to be cost effective, and you know how I feel about cost effectiveness, but it is an old standard of care that most people still follow. You're sticking their, you're sticking them for blood work anyway. That's kind of the theory. But generally, if something has happened, if there were a car accident or a placental issue, you likely would have known about it. So you wouldn't need to test her antibody screen again, but it is still typically done. And then, but you can give her RhoGAM injection that day without waiting on the test results. So usually this is all done in one visit. It can be given deltoid or gluteal. It's kept in the refrigerator, so I think that's more of the discomfort than anything else. It's just like any other injection. Doesn't feel great for a few seconds, but then it's over. The reason, if you give it early in pregnancy, which we talked about a little bit, let's say she had bleeding early in pregnancy, right? And she received RhoGAM at that time, doesn't matter. You give it again, always at 28 weeks. Because the theory is it only maintains that safety for about 12 to 14 weeks. So that's why it's given here. Now you're going to hear my other dog chew on her bone. Again, second trimester screening for anemia, and then usually you want to do your depression, anxiety, and interpartner violence screening. So you'll see that most things are done in groups, which makes things much easier to remember for you. So at that new OB visit, this group of stuff is done. That long, great big group of things is done. If she's doing birth defect screening, that is done at a certain time. Then this group of things are all done at the same time. And then about 35 weeks, you have another group of things that happen at the same time. So first trimester, 28 weeks and 35 weeks are generally your big things, your times to remember groups of things. So a hemoglobin of less than 10.5, and I know some places test hematocrit, but when you follow the guidelines, that's actually the answer to the question is based on hemoglobin. Requires an iron supplement. So you're going to see much lower than this. You're going to see normal. If you've watched your videos, then you will know that the body, the maternal blood system, will increase its volume by almost a third, because that's how much blood the placenta takes to keep it full. And obviously, as the baby grows, the placenta will grow as well. So all of that extra blood is required to perfuse the body and the placenta. So we call this, not this, but we call that, you'll see a drop in hemoglobin and hematocrit, and that's called dilutional anemia, not delusional, but dilutional. So anemia of dilution, which means that the number of red cells in hemoglobin and hematocrit have not changed or decreased, but there is more fluid there. So if you see an 11, which officially may be on your lab reference as anemia, you don't have to treat it unless it's less than 10.5, unless she's symptomatic. Okay. She's going to start to get tired again about 28 weeks. So, if she's complaining of fatigue or looks pale to you or has any symptoms of anemia, I would treat it anyway. Even if it's right just above that or at 11. And then you're going to do these periodic screenings here as well as a standard. Okay, so the blood work, the results that you've just drawn. So diabetes of pregnancy, gestational diabetes is, hold on one second. So diabetes of pregnancy is in reaction to the changes in all the maternal hormones, placental growth hormone, mom's, maybe pre-diabetes state, obesity. Those things are kind of going to lead to that. It can also happen in a completely low risk woman that you had no idea that she was, at risk for that. So the prevalence of gestational diabetes has increased over time. Do we know if it's because more women are getting prenatal care and having their testing done and we're diagnosing it more? Or is it because we've changed these screening practices? The cutoffs for the results kind of change all the time. Not all the time, but they change. So who knows? Who knows why? One reason, advanced maternal age or moms who are 35 or older at delivery do have an increased risk of gestational diabetes, and we do have more and more older moms. So that could probably contribute as well. It is one of the most common medical complications of pregnancy. And you will see pretty quickly that in moms who have one problem, they often have other problems. So they start to develop one complication, and then you'll see another and another. So the approach that we use for screening is what I just said before. So you do that first screening with 50 grams. If they fail that, and again, that is a different cutoff generally per practice and if they're fasting or not. So some physicians or some healthcare providers do 130, some 135, some 140. There they are, 130, 135, or 140, depending on if they're fasting or not and what they have set as their guideline. And those are all listed as guidelines to be followed. So it's not like someone's just picking a random number. If their 1 hour is over 200, do not do a 3 hour, do not do the next step. That is diagnosed with gestational diabetes, and you just proceed from there. So when that test result is out of range over those criteria, then what we do is called a 3 hour or a diagnostic GTT. Sometimes you'll see it called OGTT. OGT, basically, it's just telling you it's an oral glucose tolerance test. So the 28-week 1 hour is a screening test, right? So we know how to explain what a screening test is. So if you're calling back a mom and she has barely failed out of that range, or she's out of the range, you're cut off, you're not calling to tell them that you have diabetes of pregnancy. You're calling to tell them that this was a screening test and there are always false positives. So what we're going to do is a diagnostic test. It is not a nice test either. This one is done fasting. They come into the office or to the lab and they are given a fasting blood sugar is drawn. They're given 100 grams of glucose and their blood is drawn every hour for 3 hours. They can't eat, chew gum, any of those things during the test. I'll let them chew sugar-free gum. That's not going to affect anything. You can give them ice chips. They can sip on water. Water isn't going to affect this. It's not going to dilute the test that much, but just keeping something kind of cool in their mouth. But fasting at 28 or now 30 weeks, depending on when she's doing the test in pregnancy, is pretty rough. And then, we've all felt bad when you ate a lot of candy and you shouldn't have, and you don't have diabetes. So, and you're not pregnant. So you can imagine it's not great. I have ladies who sometimes need to lay down somewhere. Sometimes they ask to go lay down in their car. I'm like, no. I have seen a young, healthy woman, it was actually not even 3 hours. It was just her 1 hour screening. And we laid her down to listen to the heartbeat, sat her up, and she said, I don't feel so great. And she got up to stand up off the table. And before we could even realize what was happening or try to catch her, she just face planted on the floor. So she had to go and have a tooth replaced. So no, you don't, again, depending on your facility's guidelines, but we don't let these people leave. Some places will, give them the drink and say, drink this before you come in or drink this when you're in the parking lot. That's fine. Whatever your facility's guidelines are, just really give specific instructions about how it can make them feel. So there are, again, 2 diagnostic criteria for the interpretation of the 3 hour test. So diagnosis typically is made by 2 elevated values. The most common, the one on the left is your more conservative measurement. See how the fasting is lower, and that 1 hour specifically is lower. So a lot of providers use that group on the left. That is also what I use in my practice. So let's say her fasting is 100, which is, not uncommon. But the other 3 hours are normal. She does not have diabetes of pregnancy. If her fasting is normal, her 1 hour is 190, and the other 2 hours are normal, she does not have diabetes of pregnancy. Now, if her fasting is, 120, and her 2 hour is 160, although you're like, that was not too bad, that's still 2 criteria, and the fasting is the best number to judge anything by, right? Just like when you do with a non-pregnant diabetic, that fasting blood sugar tells you a lot. So this is typically the cutoff criteria, but again, that's going to depend on your facility. So at by 28 weeks, a viable pregnancy, the uterus is growing, and you had a dating ultrasound at 8 to 10 weeks gestation with a viable pregnancy. Fetal loss rate at 28 weeks is very low, 3%. When it happens, it's beyond horrible, but it is very, very rare. So you can, rest a little bit knowing that. So again, there's some measurements that I talked to you about. After 20 weeks, the fundal height should correspond pretty closely to the week's gestation. So within 2 to 3. Generally, if let's say there's a discrepancy by greater than 3 centimeters, you're going to do an ultrasound to see what's going on. Is this baby not growing as he or she should? What's going on in there? Is there not enough amniotic fluid? If it is someone who is a little tiny person, she was a tiny person when she was born and she has a tiny baby, and you have a good ultrasound and she always measures 3 centimeters under, and you still have an ultrasound that says this is a happy baby, then that kind of becomes normal for her. And that's called a small for gestational age baby, which you still monitor. But again, that's something we'll talk about more in the 3rd trimester. But if you see that, some clinicians are more conservative and will use that 2 centimeter cutoff. In some women who have that very central obesity, you really have to get in there with the back of your hand to feel the top of the uterus. So the picture that you see there, sometimes it works that way. You've seen all types. So if you have, a mom who is thin and healthy, and that looks like she's measuring about 25, 26 weeks, little belly there. And you can see how the provider has the one hand down by the pubic symphysis. You actually want to feel that bone kind of under there. That's how you know you're all the way down there. I do a trick. I turn the measuring tape over, which I think is what she's done here, so that I can only see the inches. And I don't do math that quickly to calculate it. So I can only see the inches. So I'm not talking myself mentally somewhere subconsciously into it being right? Because if then you're like, oh no, and you kind of move it around, like trying to make it make sense to you. But if you just look at it this way, then and I just keep my finger there where the inch is and turn it over and look at it. If it matches, good. If it doesn't, okay, let's figure out what's going on. So, and I really want to find the top. So you really want to find the fundus. So in those moms who have a more retroverted uterus, it does come forward a lot in pregnancy. It just has to. It doesn't have any way to go. But, as you've already seen, every body is shaped differently. And I don't mean everyone. I mean, literally, our bodies are shaped differently. So sometimes you have to do things a little bit differently, but that will come with experience. So again, all major organs and systems are formed by the 12th week, and they are developed or completely formed by 20 weeks. Then the placental development is complete. The umbilical cord thickens. So remember, at the end of the 12th week is when the progesterone production is completed from the corpus luteum and transfers to, the placenta takes over all of it now because the placenta is completely developed. Now that corpus luteum on the ovary starts to resolve. The umbilical cord gets nice and thick and surrounded by Wharton's jelly, which looks like, if you've ever cut an aloe vera plant for a sunburn or used aloe vera sunburn gel, it does look like that when it's out of the umbilical cord. So by the end of that second trimester, the fetus is 13 to 16 inches long, weighs 2 to 3 pounds, which is crazy that something that tiny can cause so many changes in the body. So again, this is kind of at the beginning of the second trimester. If you've seen a viability scan or dating scan at 8 to 10 weeks, those babies are moving in there. So those that neurological system is working. If you ever look at a video of how a fetus, how we all developed due to that folding of the neural tube, we kind of are made from the outside in. From sides to middle. So the eyes move toward the face and the ears from the neck to the side of the head. That's the reason that you have a limb on one side and the other on the other side, and they're supposed to match because we're formed that way by the folding. They've developed some reflexes and they can respond to stimuli. I love these pictures. So the most important is that the growth and the development of the brain is beginning there at the second trimester. Fingers and toes, the skin starts to get covered with lanugo, which is that very, very fine hair. Their hair begins to grow. They start to get some fat deposits. So that's the fat is what we're trying to get on the baby. We like chubby babies. We don't like skinny ones. And then this is a super rapid one. We love them, but we prefer them to be fat. Rapid growth in weight and size. And currently, a fetus can survive outside the uterus in the NICU at 24 weeks. I know some places will try earlier, so 23 weeks. So that's essentially telling you how formed a fetus is, almost a little bit halfway through pregnancy. Obviously, we don't have lung development. We don't have complete neurological maturity, but at 24 weeks is considered viable. Okay, I'm going to pause this. You can not have to watch all of these at the same time.